Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Welcome to those of you who are able to join us today during our special edition Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer here at GoTo Foundation for Lung Cancer. And for those of you who may not be familiar with our Living Room program, it's a support and education series created specifically with patients and caregivers in mind. The goal of which is to bring you live and in real time educational talks from key opinion leaders in the lung cancer community, and in a format and language that's easy for you to understand. We are so happy to have all of you here today. It's been a while since we've had a special edition, but it's even been a longer while since we've given an update on COVID and vaccines, in particular, how it relates to the people in our community. Today we have Dr. Jorge Gomez, who's the Associate Director for Clinical Operations, Center for Thoracic Oncology, Assistant Professor of Medicine, Tisch Cancer Institute, Econ School of Medicine at Mount Sinai. We also have with us Dr. Jennifer King, who's our Chief Scientific Officer here at GoTo Foundation for Lung Cancer. And we're welcoming back Dr. Amy Moore, Vice President of Global Engagement and Patient Partnerships at Longevity Foundation.
Today, obviously, we're talking about COVID-19 and lung cancer, so I'm going to speak specifically to and add on to Dr. Gomez's comments because we're doing a collaborative project with Mount Sinai and an entire group of fantastic investigators to really understand the impact of the pandemic and vaccination in people who've been diagnosed with lung cancer. So looking forward to talking about that more today. Thanks, Danielle.
Thanks, Jennifer. That's a perfect segue into the program. And I'll just jump right in and start with you, Dr. Gomez. Can you talk a little bit about the U54 study that Jennifer's referring to and why it was started, what it is and why it was started?
So this study is actually a large study that we're doing in partnership with multiple other entities. First of all, patient advocacy groups like the GoTo Foundation, and other academic institutions like the University of Colorado, UT Southwestern. This study is really a study to look at the differences in immune responses between patients with lung cancer and our other individuals without lung cancer who form our control group. We're studying several different things. First, we're looking at the antibody levels. Antibodies are what your body makes to fight either infection or cancer. But we're also looking at the immune cells in these patients, not only around the time of vaccination, but throughout the course of their treatment. The body has a lot of different immune cells that carry out different processes. And we can measure those. We can take a look at the number of cells, the quality of the cells, and whether there are immune cells that are specific to COVID, to SARS-CoV-2. And that's very important so that we can get a sense of how our patients with lung cancer are able to respond to either infection or to vaccination. You know, there are a lot of factors that contribute to a person's immune response. And in the case of patients with lung cancer, there are patient-related factors. There are cancer-related factors like the type of cell, which may or may not be more susceptible to being infected by SARS-CoV-2. And then there are treatment factors, and those are obviously very important since we know that chemotherapy specifically does or can cause immune suppression, and immune suppression has always been a problem in patients who need vaccination. So we're looking at all of the characteristics of patients with lung cancer and individuals without lung cancer, like age, ethnicity, the type of cancer, the type of treatment that they're receiving, whether they've gotten a flu vaccine, and how these factors affect their response to either the COVID-19 infection or vaccination against SARS-CoV-2. And so we draw blood at a baseline visit at 3 months, 6 months, 12 months, and 24 months to look at all of those things. And there is a part of our project where we are drawing blood on the day of vaccination and on the third and seventh day to look at kind of the immediate response of the immune system to vaccination.
I want to bounce a little bit around in the agenda just because I want to make sure that the folks watching understand sort of how the vaccines work. You talked about measuring antibody levels as well as immune response. So Amy, can I jump to you really quick? And can you just give us an overview, a little bit of an overview about the COVID vaccine and how it works?
Well, here in the U.S., we have 3 vaccines that we are working with. So there are 2 that are mRNA-based, both Moderna and Pfizer. And then there's the third vaccine, J&J, which is using a virus called adenovirus, which doesn't really cause problems for most humans. It's kind of a common cold virus, if you will, but it functions as a carrier to deliver the instructions for making the spike protein. So in both cases, you get vaccinated, so you get a shot in the arm, which induces your immune system to mount a response. And that response is layered. So we're all very much focused on antibodies, but that's one indication of an immune response, and it's an important one. But we also have something called T cells. So together, both the antibodies and the T cells can help combat virus infection in different ways. And so I think throughout our discussion, even though the focus today is primarily going to be on the antibody response, I think we need to be aware that in addition to that, patients, individuals who get vaccinated also mount what's called cellular immunity, which is the T cells. And so that also confers additional protection, which may be longer lasting in some cases. So T cells and B cells are capable of memory as well. So they know things they've seen in the past. So that's, at a high level, what we're talking about is we have mRNA or adenovirus vectored vaccines that can induce T cells and B cells.
Great. Thank you, Amy. Dr. Gomez, can you talk you talked a little bit about the study, what it's about and why it started. Can you talk a little bit about some of the findings that have come out of that study?
So we're still somewhat early in the study. We're probably about a little less than a quarter of the way through, but we've been able to get information from our volunteer patients and our control volunteers that has given us some pretty good insight or some insight into what's going on. I think that the most important thing that we have found is that the majority of patients with lung cancer are able to mount a good immune response when they either have the infection or they're vaccinated. Initially in the study, it looked like these responses were a little bit lower than in the control group and in the patients without lung cancer. And that they came down a little bit faster. That's still something that we have to tease out. But in spite of receiving chemotherapy, in spite of having lung cancer, the majority of patients are able to mount a good immune response. However, there is a small group of patients, and that's about 5% of our patients, who either do not have a response from the start or who mount a very low response and quickly go back down to 0. And so that group has now become a very important group for us because our main goal when we started the study is how do we protect patients with lung cancer? And fortunately, it turns out that maybe a lot of patients with lung cancer don't need more protection than we're giving them by vaccinating them. But there's a group where we have to figure out how to save them, how to protect them from this virus.
And is that albeit small percentage of patients who don't respond just in the lung cancer patient sort of cohort of this study and not the otherwise healthy people? Or are you seeing it in
That's
both?
correct. The control group has not had that issue. That really has been in the patients with lung cancer. One of our goals is to try to find out why. And so we're looking at these characteristics that I was discussing, whether they've received chemotherapy, immunotherapy, whether they've had other issues, a flu shot, or whether there are issues regarding the cancer itself, the biology of the cancer itself that makes it that makes it stop the immune response.
Jennifer, I want to jump to you really quick and see if you might be able to add to some of what Dr. Gomez is talking about, but from the patient perspective.
Sure. I think he hit on what is really the most important point that we want to make sure that all of the patients and caregivers watching convey, which is that 95% of the people that we've seen on study who've gotten vaccinated have a good response to the vaccination and are protected to similar levels as the healthy controls. So that really provides the information that we needed as an organization and across our community to be able to confidently say, yes, you should be going out and getting your vaccination if you haven't already, following all the guidelines, getting booster shots when appropriate. So far, all of the data that we've collected really supports that and shows that for the large majority of people, not just the majority, nearly 95%, are having a good response. So that I think is the number one take-home message for the patient community of what we've seen in that data so far. As Dr. Gomez said, we're extremely interested in the group that didn't respond, why perhaps they didn't respond, and then the follow-on questions about what can we do to make sure that they have adequate protection. But for now, we know that for most people, they are having a good response. You should get your vaccines. You should continue to follow all public health guidelines where appropriate, masking, social distancing, all the things we've been hearing about for a long time during the pandemic. But that is the number one patient take-home message. So for everyone who's calling us and all of that, we are highly recommending that you do get vaccinations according to guidelines.
I'm sorry I interrupted, but if I can just add one little point to that goes just to that. We also have seen in the study at least one individual who started very low, went down to 0, and came up to a very respectable number after boost vaccination. And so it's clear that vaccination is critical.
So it sounds like the general consensus is get vaccinated, right? Which I think we all internally knew, but I think it's an important point to drive home to our community and others that may be watching. Dr. Gomez, what do you tell your patients who might, in spite of all of this, still be concerned about getting the vaccination for one reason or another?
So what I can tell them is really, I show them this safety data. There are some side effects to the vaccine, but in general, it's a very safe vaccine. But even more important than the safety data is the efficacy data and the terrible issues that go along with having COVID. Early on in the pandemic, we saw multiple reports of SARS-CoV-2 infections in patients with cancer, and specifically in patients with lung cancer, showing a very high mortality rate, significantly higher than the vast majority of other groups. And so protecting yourself against that is key. Patients with lung cancer who have COVID are at a significantly higher risk for having complications from the disease. And so they need to do everything possible to prevent it.
So a couple of questions are coming in from online, and I think this is a perfect spot to kind of bring them in. One is a patient who's saying they've heard a little bit about blood clots after having COVID and people actually dying from that. What is the sort of truth behind that? Amy, I see you nodding. If you want to take a first stab.
Yeah, I can take it. What we know is clear is that SARS-CoV-2 infection and COVID disease greatly increases your risk of clotting disorders. So I want to separate that out from concerns about the vaccines causing clotting. Now, that did emerge as an issue with very rare, 1 in a million kind of stats around the J&J vaccine. So people were concerned, if I get vaccinated, am I going to get a blood clot? COVID, it greatly has much higher risk of blood clots than vaccination. So I want to kind of reassure the community that vaccines are safe, again, to reinforce Dr. Gomez's prior statement. So yes, SARS-CoV-2 infection and COVID puts you at great risk of clots and poor outcomes. So that is very true.
There's another sort of more of a comment than anything, but I think it's important for those watching to also hear this. It's a patient who has received all 3 shots plus a pneumonia shot, and then did ultimately test positive for COVID about a week ago. Having stage 4 lung cancer for 3 years, ALK positive, but she's very thankful that she's feeling much better and ready to get back in the game. So that's kind of exactly what we're talking about. Were she not vaccinated, this may not be the same type of outcome. The other question, Dr. Gomez, is from a survivor who's saying they got all 3 vaccinations, but they only have 1 lung. Does that put them at more risk of potential complications would they get COVID? I'm assuming that's...
And that is correct. Having 1 lung means you have a lower capacity, a lower lung capacity, and if you were to develop more severe COVID, you would be at higher risk for a lot of different things, including dying. And so that is, again, one of the biggest arguments for doing the full vaccination.
And I think there's an important point to be made with a couple of those comments that the vaccinations, we are still seeing some breakthrough infection even at the time of vaccination, but there's very strong data that the risk of severe COVID-19 infection, hospitalization, death is still greatly, greatly reduced in those who are getting those kinds of breakthrough infections. So even though, yes, probably all of us might know someone who's had a breakthrough infection or was still infected after their vaccination, what we're not seeing is the same level of severe infections, the same level of mortality that we saw pre-vaccination during the pandemic. So there's still a huge benefit to the vaccination when you are looking specifically at that category of severe disease, hospitalization, and death.
I think that's an important point to reinforce because the vaccines are holding up very well. You know, we talk about waning and reduced efficacy, and, you know, they still perform quite well against severe disease, hospitalization, death. You know, some of the waning is more in the context of the infection piece. So, but, you know, our bottom line is we want to strongly encourage our community not only to get vaccinated, but to get their boosters as appropriate.
And Amy, since I think this is an incredibly important point to make, because I think there is a lot of scuttlebutt, if you will, out there about, well, why get vaccinated if I can still, you know, contract COVID-19? So what, 2 questions, and I'll let you all kind of take it where you see fit. One, we've used the word efficacy a couple of times. So if someone wants to explain what that means to the population of folks who are watching that might not know, that would be helpful.
Well, I mean, basically, it's just a measure of how well the vaccine is protecting individuals against different measures. So we talk about efficacy against infection. We also talk about efficacy against, you know, worse outcomes. So severe disease, hospitalization, and death. And so I think the challenge, or where it gets confusing for people, is sometimes those things kind of get lumped together. And when we're talking about efficacy, we need to know what we're specifically referring to. Are we talking about, you know, effectiveness against infection, or are we talking about effectiveness against severe outcomes? I don't know if Dr. Gomez or Jennifer have things to add.
No, I think that covers it fairly clearly. There are different goals with the vaccine, and those are pretty much the 2 most important, which is preventing infection and preventing severe infection and death.
So we talked about these breakthrough cases just a little bit. Do we know what the percentage of breakthrough cases, what that number is in fully vaccinated folks? Well, let me step back from that. First of all, can we define what fully vaccinated means?
So currently it's still defined as 2 doses of vaccine if you're getting mRNA vaccine, and a single dose if you're getting J&J. But I think it's a question of when, not if, that definition is going to change, because in the face of this ongoing protracted Delta surge, as well as in the face of the new variant Omicron, what is becoming clear is that boosters are probably necessary. And we're even getting to the point where we're discussing, is a fourth shot warranted? So I think we're very quickly moving to fully vaccinated being 3 doses. And then time will tell if a fourth dose is recommended.
Yeah, potentially for patients who have moderate or severe immunosuppression, 4 doses may be appropriate.
And these are all sort of some of those things that we're still trying to figure out, right? And I know we aren't really that far out from the beginning of the pandemic and this virus, and so you only know what you know when you know, which is not really a great answer for a lot of folks out there who are like, it's not making folks feel real confident, right, about getting it. But I think the good news is, and I think what U54 is showing, at least in the early data, is that the benefit way outweighs the risk. So there's another question from online regarding NED or stable patients who may be off treatment. Are they at as high a risk of developing serious cases of breakthrough COVID if they're vaccinated?
So the risk of developing breakthrough COVID is probably the same as everybody else. The risk of having severe COVID disease or having complications depends a lot on their baseline functional status, how good their lungs are, how close their lungs are to normal lungs. Again, in patients who've had surgery, who have had part of the lung removed, they may have a lower respiratory capacity, and so they again would benefit from vaccination and lowering their risk for severe COVID. But in someone who potentially had a tiny nodule removed and has a full lung function, there should not be a significant difference.
I would add that the patient might want to be mindful of when their second shot, if they got mRNA-based vaccines, was. If they're 6 months or more out, then I would say that risk starts to increase a little bit, of getting breakthrough infection. So they would definitely, based on, again, to Jennifer's point, guideline recommendations, want to get that booster if they're 6 months or more out from Moderna or Pfizer, or more than 2 months out from J&J.
So staying sort of in the vein of conversation around the risk, and then going back to a question that I meant to ask earlier, at least I started to, what is the percentage of folks that ultimately will develop some sort of breakthrough infection?
I'm not sure of the exact number. I know that it's low. We've had some issues initially, with tracking that and honestly, data transparency at a national level and how those cases are reported. So while I can't give you a number right now, I do know that it appears to be still reasonably low. But, again, in the face of Delta, in the face of, and we'll get to Omicron in a little bit, that's expected to potentially go up. The first signals we're seeing about Omicron is it does seem to be more capable of inducing breakthrough infection. So time will tell if that is true. But, again, it's important to make sure you're fully vaccinated and boosted.
Yeah, while we don't have very clear data of what the actual number or percentage of breakthrough infections is, we do have a lot of reports from different states showing the difference between the incidence of COVID-19 disease in patients who are unvaccinated and in vaccinated patients. And that is a huge difference. The numbers of breakthrough are very, very low compared to the numbers of people who are getting COVID who have not been vaccinated.
I think that's a really good point. I want to circle back a little bit to, and Jennifer, ask you if you could speak maybe to some general inquiries that we've received about the vaccine in particular for lung cancer patients, and then maybe the three of you can talk a little bit about your recommendations based on some of these inquiries.
Yeah, honestly, I think we've touched on a lot of them. Initially, there was a lot of hesitancy around side effects of vaccination. I think it's been very well shown that the vaccine is safe, even in people with cancer and lung cancer specifically. The one thing, and you sort of mentioned this before, one question we get is, the recommendations keep changing. How do you trust everything when it's constantly changing? And fortunately or unfortunately, that's sort of the nature of science and how science works. I think, one of the sort of normal things to scientists is you develop a hypothesis and you go test it and see if it works or not. Huge amounts of time, it doesn't work. So we are always testing what we know to see what's correct, what's not correct, and then how do we move things forward. And this pandemic is not any different than that. We are, all of the recommendations are based on the best data that is available at this time. And there are hundreds, thousands of research groups out there who are really trying to contribute to that body of knowledge in meaningful ways across many countries. As Amy talked about, there's different variants, there's different geographic availability of what's happening where, and how we need to think about that in the case of different vaccine approvals and different variants. So unfortunately for the patient community, the recommendations likely are going to keep changing over time. But what we need to do is sort of make the best decisions at the time, which is what everyone has been trying to do, and where a lot of what we're talking about comes today is based on the data that we've seen, that we have in hand, and we continue to ask questions so that we know how to proceed in the future.
I think one point is that in the beginning of the pandemic, information kind of did change. But now, more than changing, it's actually evolving and being refined. And so I think we have learned a lot of very good things, and we're just making them a little bit better and a little bit better, rather than being real changes and saying, oh, this really doesn't work.
But you have to be mindful, too, that we're in a very fluid situation. We're in a pandemic that's evolving in real time, and that's evidenced by the emergence of, the latest variant. And, that's the reality, unfortunately, back to Jennifer's point about global differences in vaccine availability, vaccine equity. This variant, we're not sure where it emerged. It likely did not emerge in South Africa, but there are places in the world that don't have access to vaccines yet. And as long as the virus has people to infect, it can continue to change and evolve. And so until we get the world, really protected, we're all at risk. And so that's the bottom line. We need to keep reinforcing that message of vaccination and taking other public health precautions to keep the virus at bay until we can get a handle on the pandemic.
Can you talk a little bit deeper, I guess, about what causes these different variants? Because I think there's a lot of question out there about what's causing this to go from the original virus to now. And I know we're going to talk a little bit about where we are now with Omicron, but what causes those variants to sort of bubble up?
Well, I think,
is the virus getting
in the
smarter,
simplest term,
Yeah.
It's kind of an evolutionary struggle between the virus and its host, right? So we're trying to develop vaccines and other therapies, antiviral medications, monoclonal antibodies. There's a whole kind of armamentarium of approaches that we're using to try to keep the virus in check. But as we're trying to protect people, the virus is trying to find that competitive advantage, right? And so with Omicron, again, what we see is that it has this kind of collection of changes, 30 of which are in that spike protein, the little knobs that protrude out of the virus. That's where the virus binds to the host cell. So, and that's the target of, these antibodies that are generated by vaccines. So if it can change ever so slightly, maybe it has the ability to evade the defenses we're throwing at it, to evade those antibodies that our vaccines are generating, or to evade those monoclonal antibodies. And that gives it an upper hand. So it's kind of this, fight between the virus and the host and who's going to win.
So what would you all say to the folks out there who might still have some concerns about how quickly these vaccines were developed and made globally available? I know a lot of folks have a problem with that because they have historically thought, well, these new drugs go to trial, half of them never even make it, more than half of them never even make it, right? And those that do take years to get to this global sort of place. How did this happen so quickly And what would your response be to the folks who are still hesitant because of that?
This technology has been in development for literally decades, and was already being mRNA vaccines, for example, were already being tested against different types of cancer and different viruses, flu virus, Zika virus, and others. So it just happened that all the pieces that we needed were kind of ready to deploy at exactly the time that we needed them. And so I know it comes across to the public as, wow, this technology sounds so kind of new age and it's scary. It sounds, there's RNA and genetic, and is it going to alter my DNA? But the reality is the science was there, and we were just able to tap into it precisely at the right time.
And I think too, just sort of from a logical standpoint, at least for me, it makes sense that this was a study or a trial that literally everyone on the planet qualified for, right? So accruing patients into the trial was not as tough a challenge as it is for some cancer drugs, for example.
And there was a lot done kind of on the back end that people don't see too, to reduce some of the typical slowdowns and regulatory burdens, things like that, to be able to get these trials through. A lot of agencies, institutions really prioritized this research because they knew what a huge impact it could have on public health. So in many, many settings, if there's a line of studies to review, this type of stuff went to the front of the line. And so a lot of time can also be saved by the prioritization that we saw of how important this was and why it needed to happen now in order to save all of these lives.
Yeah, that makes sense. Dr. Gomez, with all of this being said, I'm curious as to your experience with your patients. Do you get, are patients willing, without a whole lot of question or prodding, to get the vaccine, or are you still having to kind of have some of these longer conversations?
Yeah, that's difficult. So we do have a large proportion of patients who are eager to get vaccinated. When they heard that a booster was approved, they ran over to get their booster. But we have a group of patients who do not want to be vaccinated. And in our study, for example, initially, it's now about 20 to 25% of patients who have declined to be vaccinated. And so they are still concerned, and they're concerned for, or they voice concerns for different reasons. They are concerned about their immune system. They're concerned about other things that are, other issues that they hear or they see on the internet, memes about the vaccine. All we can do is really try to show them the data, show them what has been found, that these vaccines clearly work and clearly can prevent the infection or hospitalization or death, and lead by example. And so I'm, in clinic, I say, I got my vaccine, and recently I said, I got my booster.
Yeah, I find myself doing the same when I encounter people. So are there other, and Jennifer kind of touched on this, and you've all touched on it a little bit about the concerns about people are worried about their immune system. What are some of the side effects? Because I know people talk about, I'm so worried about the side effects, and I'm kind of like, which side effects are you worried about, right? Because I know with all three of my shots, every shot I got dropped me for a day. The first one, actually a day and a half, but all three of them just knocked me out, right? But other than that, I haven't had any side effects. So what are some of the legitimate potential side effects? Are they short or long term? And how do you have that conversation with folks that might be concerned about it?
I'll start just from the personal perspective. The vaccine has, or the vaccines, all of them have been shown to be fairly safe. There have been rare reports of significant side effects, but for the most part, the side effects have been, pain at the site of infection, flu-like symptoms for a day or so, and I experienced those in my second and my boost vaccination. I did have 2 days where I was not feeling well. But again, for the most part, these are safe vaccines, and we have millions and millions of people to show that.
I think, unfortunately, Danielle, for people that do focus on side effects, they get scared of the very rare side effects. So, as Dr. Gomez alluded to, myocarditis, heart inflammation, was one that emerged in context with the mRNA vaccines. And that's particularly true for younger males. And then, of course, with J&J, as I mentioned earlier, there was this rare, 6 cases, and maybe there are a few more since then, but the initial report that caused the halt of J&J temporarily was 6 cases of this rare blood clot in the brain in younger women. So, I think, again, we want to reinforce that by and large, those are extremely rare side effects and complications, that the majority of patients are going to do just fine, that the profile, half the world's population has been vaccinated at this point. So they are extremely safe, and the benefits far outweigh the risks.
So would it be your opinion then that those that may think, well, or be saying, I haven't felt the same since, or I get, headaches, or I had like that, do you think some of that might be psychosomatic as opposed to actually, a side effect, or are some of those things longer term in even a small, minor, but legitimate?
I don't think we want to
We don't know.
dismiss anybody's, but the good thing is there is a tracker where you can report adverse events. And so usually when you schedule your appointment or get vaccinated, you should be given information about that so you can input your side effects. And I think that helps give us a clearer picture, right, of things that may emerge. But again, we have to vaccinate large numbers of people. Like, we didn't detect this rare blood clot with J&J. It's 1 in a million. So you've got to get, enough people vaccinated before you're going to detect some of these very rare side effects. But, I think the most common things, I just got my booster this past weekend. I had chills, I had body aches, I had, a headache. And that, I had a sore arm, I didn't want to lay on my arm when I was sleeping, but that, lasted for a few hours and then it lifted. And now I have the, reassurance of I've been boosted, and I feel confidence in that. I'm going home for the holidays, and my mom was recently diagnosed with breast cancer. And, I want to be around her and have that added assurance that I'm helping protect her too.
Yeah,
and I think
love
to
that.
answer that risk benefit is really important, that yes, there are very, very rare risks, but when you start to look at the numbers of what do the risks look like in the vaccinated population versus the unvaccinated population, even some of the things you're talking about, it's much more common to have, long COVID than it is to have headaches post-vaccination for a long period of time. I do think, as everybody has said, those flu-like symptoms, that initial reaction to the vaccination is very common, and many, many people are reporting that. But beyond that, and the sore arm, most of these things are extremely rare. And, even the myocarditis, I have a young son. I asked my pediatrician, you want to do your due diligence? I said, what do you think of that? I looked at some of the data myself. And yes, it has happened. But in the end, when I looked at, what are the potential risks to him, or to Amy's point, other members of the family, because we also have family members with various health issues, the very, very small risk was really worth it to have the decision to have our entire family vaccinated. So I think everybody needs to have that risk benefit conversation for themselves and with their doctor. But as I look at the data, it comes out strongly in favor of vaccination.
So we got another question from online, and I don't know that we have a good answer for this, but there's someone asking if there's some place that they can sign up and or be in a study that will monitor the immune response post-vaccination and or booster.
So there are a lot of places, a lot of institutions that are actually running that type of study. It's obviously important to find somewhere local, because you'd have to go and periodically have blood drawn. If you'd like to come to Mount Sinai, we will certainly welcome you and help you But again, there are reports from a lot of different institutions throughout the world who are monitoring their patients, and so that can be done. It's important to ask your doctor.
Yeah, and I would just add that this is our U54 is part of a larger effort funded by the National Cancer Institute called SeroNet, which is about 25 institutions across the nation, which are, doing similar variations on the theme of studying the immune response to SARS-CoV-2 infection. So this is a national network of institutions who are working to study this and to better understand the immune response to virus infection.
And part of what GoTo is doing on the U54 study, besides providing patient advocacy input, is helping some of our centers of excellence to also start to open this study so that we can have it recruiting more broadly than just the Mount Sinai and New York area. So we're hoping we'll have more sites to be promoting for this particular study soon. But to both Dr. Moore and Dr. Gomez's points, there are multiple studies across the country and around the world who are looking at this type of thing.
I think it's a great point, and I know that finding studies is not always the easiest thing for our patient population. So if anybody does want more information or does need some help on navigating that process, please reach out to us and call our helpline, and one of our lung match navigators would be happy to walk you through that process. One more question. I think we're going to get to this. So what I want to do, because I want to be mindful of time, because I think, Amy, I want to talk about the new variant, Omicron, and I want to talk a little bit about how to stay safe during the holidays, which is the question coming on. But let's go ahead and start with whether or not all strains are the same. If they're not, how are they different? We've already talked a little bit about it, but more importantly, what do we know so far about this new variant?
So yes, the news about Omicron broke the week of Thanksgiving. So scientists in South Africa have been very vigilant about kind of doing surveillance for potentially new strains that have emerged. And so they sounded the alarm that they were detecting a new variant called Omicron. And again, we give these variants names. This is a letter in the Greek alphabet, so not according to their place of origin. We don't want to stigmatize countries or people because variants can pop up anywhere. So that's how the terminology was determined. And so that means we've had, everybody's Delta is fresh in everyone's mind, and we need to reinforce the point that Delta is still causing over 99% of cases here in the US. But Omicron, what's different about it is it has about 50 changes compared to some of the previous variants. And, it's a weird mix. Some of them occur in earlier variants, but some are new. Most worrisome to scientists was, again, I mentioned earlier, kind of 30 changes in the spike protein. And again, that's the piece of the virus that binds receptors on your host cell. That's how the virus gains entry into your cells to cause infection. And so the concern was that with so many changes, it may be able to infect our cells more easily. It may be able to escape the defenses that we're throwing at it and by way of vaccines. So I'll pause there and let you ask additional questions.
Yeah. So how, I think this is sort of stepping back a little bit, but for those newly sort of diagnosed COVID patients, how do they know which strain they have? I mean, I know people who have fortunately recovered, but they don't know which strain of COVID they have.
Right. And so by and large, you're not going to know what strain you have when you go out and just get a PCR test or do a rapid antigen test. The way we know what strains are circulating is there are surveillance efforts underway nationally at different places. So again, the first case of Omicron was detected here in the San Francisco Bay Area, was subsequently shortly detected in New York. So we have some strategic cities in which, CDC and others are doing surveillance to kind of capture. So they're sequencing virus from people to say, is it Delta? Is it Omicron? What strain? Is it a new strain that we haven't seen before? So again, when you just do a routine test to confirm infection, yes or no, you're not going to know which flavor of the virus you have, but it's surveillance. And then we can kind of determine based on those sequences, how prevalent one strain is compared to another. And again, here in the US still, Delta is the prevalent strain.
And is there a concern, or I guess, are we looking at Omicron and its reaction to and or response to the vaccines? Do we know that the vaccine, that people are protected? Yeah, go ahead. Sorry.
That's first and foremost everybody's main concern and question. I think there are several questions that we ask. One is, first, is the virus more transmissible? And I think the early data coming out of South Africa and now out of the UK suggests that perhaps it is, and it does seem to be spreading pretty rapidly in the provinces where it's been detected in South Africa. So that's one. Will it kind of become the dominant strain? And that will be determined over time. We're still very much in the early days, but does it have a competitive advantage to become the dominant, virus that we're dealing with? And that will emerge over the does it cause more severe disease? We don't know that yet. Some early glimmers of hope out of South Africa have suggested that it may be causing milder disease than what we have seen, but that comes with a couple of caveats. Those early cases were in younger people who tend to be healthier to begin with. So the jury is still out on whether or not, what Omicron disease severity will look like in people who are immunocompromised, people with underlying health issues, older people whose immune systems are weaker. But in terms of vaccine protection, we started to get some of the first data this week from two studies. So Pfizer released some data as well as some investigators in South Africa. And what they saw in those two studies was between a 25 and 40-fold reduction in what's called neutralizing antibodies. So antibodies can kind of coat the surface of the virus and keep it from infecting cells. Now, that's a concern because obviously we see this pretty significant drop in antibodies, but it's still believed that vaccines will provide protection. But the greatest protection appears to be either for individuals who had a previous infection and have since received 2 doses of vaccine, or for individuals who've received both vaccines as well as a booster. So what is becoming clear thus far is that your greatest protection against this emerging variant is to make sure you get that booster, because that helps top off your antibodies and gives you greater protection against breakthrough infection, which does seem to be a growing concern with this variant.
Yeah, that's what I was going to ask, is in fully vaccinated people, are these subsequent variants more likely to cause breakthrough, or do we know?
Well, what's interesting about Omicron, you talked about what's the difference between the different variants that we've seen, and there is some relation among many of them. Kind of, if you're thinking about when we look at evolution, we talk about kind of branches of the evolutionary tree. Omicron kind of split off on its own lineage, so it's a little bit different than kind of these others that are grouped together or have some kind of co-occurring or similar mutations. And time will tell how that impacts many of these questions that I just laid out for you. But because it is so kind of different and on this kind of different lineage, that may have some implications for vaccine efficacy, for transmissibility, for disease severity. And so we'll know more over the coming weeks. And certainly all of us are monitoring that and we'll be addressing it as we learn more.
So again, being mindful of time because we are closing in on the hour. One of the questions that came in from someone online was, can fully vaccinated patients get together with unvaccinated family members? If so, what does that need to look like? So
that's okay. Obviously a very difficult issue. Again, because there is the possibility of breakthrough infection even in vaccinated patients. I think it's important not to let down your guard. It's important to keep doing what we've been doing for the past year and a half, almost 2 years, which is maintain some social distancing, continue to wear your mask, follow hand hygiene, and just try to be careful.
As Dr. Gomez said, it's a really difficult question, and I second what he said about as many preventative measures are as important as you possibly can. But in the end, I think some of these are very personal decisions, and we want everyone to be as safe as they possibly can, but everyone needs to make their own decision as how I personally have been looking at it.
Yeah, I think we have to be aware that we're 2 years into a pandemic, and that has profound mental health impacts as well. And it's hard to tell people coming into the holidays that you can't be with your loved ones, because we know that's important, not only for patients with cancer, but for people in general to be around people they love. And so what I advise patients or individuals, who are in this situation is to, assess your own risk profile, as others have said, but then also make choices that, responsible choices. So in places where you can, choose outdoor, meals or outdoor activities. If you're going to be indoors, social distancing becomes more important. So make sure there's ample space, provide good ventilation, open windows, turn on fans, or, that helps. And so as winter is coming and, colder weather is setting in and people are being driven indoors, I think ventilation, kind of that dialogue around shared airspace, becomes even more important. So, making sure that that's incorporated into your planning. But, we know that we have interventions beyond vaccination that can help keep us safe. And so masking, social distancing, hand washing, all of that's important too.
I'm wondering, would any of you recommend those unvaccinated folks to maybe come with a negative COVID test as well to a gathering like this? And if so, there's still, I think, some confusion around testing out there. There's, you can go to your local drugstore and pick up a home test. Is that as effective or as truthful a result as going to one of these sites, or what do you guys think about that?
I think testing is an important piece of the equation for sure. I tend to, like myself, to kind of couple both the rapid at-home test with PCR test, as kind of the gold standard. I do think that when used properly, the one I choose to use is called Binax Now, which you can get over the counter at drugstores. You just swab your nostrils and it's a quick 15-minute kind of readout, kind of like a pregnancy test, either one line negative, 2 lines positive. But, depending on where you are in your infection, that second line can be very faint. So interpretation can be, making sure you're doing the test properly and then reading the results accurately. But I think if used day of the event, so, if you're traveling or if you're gathering locally with a mixed population, it's an important layer of added reassurance and protection. So I would say testing is critically important.
Yeah, I know it's our world has rapidly evolved into this incredible space of unknown for so many people. And I know here in San Francisco and other places around the country and the world, people are requiring proof of vaccination just to go to dinner, right? Like the restaurants are asking for it before you walk in, which is kind of a new space. So it'll be interesting to see how this all kind of fleshes out. So we've got a few more minutes. I want to run through everyone and see if anybody's got any final thoughts before we close out and say our thank yous.
I think, I would say, even though it's kind of many of us are feeling frustrated that there's another variant that seems to be on the horizon, and we were hoping to come into 2022 kind of getting out from under this dark cloud, I think we still have a lot of reasons for hope. And I think, the important message for our community is that the results we're seeing from this study show that, vaccines can protect patients with lung cancer. So it's, we want to reinforce that message first and foremost. But, I think we can be cautiously optimistic, even in the face of a new variant, because we've learned so much more about the virus, how to stay safe, how to treat COVID even, but we want to keep people from getting it in the first place. So get vaccinated, get boosted.
Yeah, I'll just echo what Amy said. I think, that the hope is very important. We're in a much better place than we were not so long ago. And that number one takeaway from this study that we've been doing specifically on people with lung cancer is that 95% of the people are responding to the vaccination. And so that is a really great thing. We didn't know that going in, and we know that now. And that's a huge positive to walk away with.
I don't really want to repeat exactly what both of you guys said, because that's kind of how I feel. But I will repeat just a little bit of it. Vaccination is safe and effective at keeping people safe. And patients with lung cancer are safer than we thought in the beginning, even if they're getting treatment.
Thank you. Well, a huge thank you to all of you for bringing your expert voices to this very important conversation. And I will say to those out there, either who have been able to watch live or who will come back and watch post live later, if you have more questions, please feel free to reach out to one of us, and one of us at GoTo, and we will make sure to reach back out to the panel and get those questions answered for you. So a huge thank you to everyone. Have a wonderful holiday season and a happy new year if we don't get a chance to connect before then, and we'll see everybody soon.
Happy holidays.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.